So, Alexandra, you remember in the trial design, we had this algorithm to use IVL-ΦIrst. So we kind of came up with this idea that there's a signal from disrupt that IVL's maybe safer in women than atherectomy and severe calcium. So how about we strategize that when you need to treat severe calcium, your approach is to use IVL as your first device. Now, we were pragmatic about it, knowing from clinical practice that's not always possible. Sometimes you have balloon uncrossable lesions and you have to do atherectomy first. And sometimes, you'll use IVL and then maybe you think it's done a good job, but I need something else. So in the design, we very specifically said to people, try and use IVL as your first device. But if you can't, you need to do something else first, that's fine. You can circle back then to IVL afterwards. Or you can use IVL, and if you feel it's not enough, you can then use another device in combination. So we were really keen for this to be like a real cath lab type trial. And one of the things I was really impressed by looking at the initial procedural data from the trial was that in over 90% were able to use IVL as the first strategy in treating these lesions. And I think that is really quite remarkable. Because as we dig into the data and we see the patients that were included, these were really patients with severe, real life, severe calcium in the cath lab. It wasn't a very prescribed clinical trial type population. We worked really hard on making this as all comers as possible. I mean, the only two things we excluded was ISR and cardiogenic shock. You could put left main in, multiple lesions, CTOs, anything really from an anatomical point of view. So I think the idea that with all those patients that you can use IVL-ΦIrst in over 90% of patients, I was a little surprised how good that looked. What do you think about that?
No, I totally agree. And I think it comes back to this notion that it's a device that is much more user-friendly. And what we would like to see, ideally, is that once we come out with the results of the study, that this can be implemented in many more cath labs for more female patients to optimize the outcomes. The data that I was talking about initially, where we're seeing much worse outcomes after stent implantation, that preceded IVL, right? And we saw higher mortality rates, higher MI rates, etc. I mean, ideally, we would be able to modify the plaque, optimize stent outcomes, have better long-term outcomes for our female patients. And again, it comes back to this notion that we also in this trial didn't just want to look at the acute procedural outcomes out to 30 days. We really want to look at the long-term outcomes out to 3 years. So we'll be able to see that. But I think that the whole notion of doing and trying to quantify how many of these women, again, it's almost an all-comers study, as you said, can have an IVL-ΦIrst strategy will be so much more generalizable, right, to basically patients across the country. And I think that's very impactful. So.
Yeah.